So today we will be discussing the questions that were posted on the Telegram quiz. The topic was clinical scenarios in ophthalmology. All right. So can we start the discussion? So the first question: a 50-year-old male presents with droopiness of the left eyelid. There is anisocoria, normal extraocular movements in all gazes and no diplopia. Which of the following is the most likely diagnosis? So first of all, what is anisocoria? Anisocoria is a difference in the size of the pupil between the two eyes. Okay. So our patient has anisocoria. He has got droopiness of the left upper lid and all the extraocular movements are normal. Okay. In all the cases, there is no complaint of diplopia. Now, what is the most likely diagnosis? Now, let's talk about option A, CPEO. What is CPEO? Chronic progressive external ophthalmoplegia. Now, in CPEO, you know, all the movements are restricted. But in our patient, they say all the movements are normal. In all the gazes, the extraocular motility is full. So that already rules out CPEO. So one option is out. Now, third nerve palsy. See, third nerve palsy, will I have a droopiness? Yes. Droopiness of upper eyelid? Yes. But okay, will I have anisocoria? Yes, because on the side of the third nerve palsy, the pupil will be dilated, and assuming the other side is normal, there is anisocoria. Again, yes, anisocoria, yes. But our patient has extraocular motility normal. How would it be in third nerve palsy? It would be paralyzed. You know, all movements are paralyzed except that of SO4, superior oblique, and lateral rectus, LR6. SO, which is innervated by your fourth cranial nerve, is preserved, and lateral rectus, which is innervated by your sixth cranial nerve, is preserved. So again, third nerve palsy is ruled out. Yeah, so two options are ruled out. So now 50-50 chance of arriving at the correct answer. Yeah. Myasthenia gravis. See, myasthenia gravis can cause droopiness of the eyelids, and as you all know, most common cause of bilateral ptosis is myasthenia gravis. Raza, what did you say, type? I didn't notice. All right. And extraocular motilities may or may not be affected depending on the stage of myasthenia gravis, and so based on that, the diplopia. Yeah. But see, myasthenia gravis, write it down. Take home point from this question is myasthenia gravis will never cause anisocoria, but our patient has anisocoria. Is that clear? Write it down, put a box. Myasthenia gravis will never cause anisocoria. Is that clear to everyone? What is anisocoria? An means not, iso means equal, choreo means pupil. Okay, anisocoria is difference in the size of the pupil between the two eyes. Is that clear? So myasthenia gravis will never cause anisocoria. So the moment you see patient has anisocoria and in the option there is myasthenia gravis. Yeah. Oh, hi Raza. Okay. So myasthenia gravis ruled out. So you automatically arrive at your answer, Horner's syndrome. So Horner's syndrome, you're going to have ptosis. Yes, a mild ptosis because our Muller's muscle is affected. Muller's muscle contributes very less to the elevation of eyelid. So when its action is lost in ocular sympathetic palsy. What is ocular sympathetic palsy? Horner's syndrome. Yeah, because Muller's receives sympathetic innervation. So there will be only a very, very minimal ptosis, not even mild. It's a minimal ptosis, just 2 millimeter of ptosis that you have. Yeah, and anisocoria, why? Because Horner's side you will have meiosis, because now your sympathetic is affected. No, sympathetic means dilator pupillae is affected. So your sphincter will overact, causing meiosis. Is that clear? So that means there's definitely anisocoria. Yeah, and the anisocoria will become more prominent in dim light. Why? Because in dim light, what is supposed to act? Your dilator is supposed to act, but now it is not acting. So what's going to happen? This eye, my normal eye, my right side, my dilator will act and it will become dilated, whereas my Horner's side, it is not acting. So the anisocoria will become more exaggerated or more prominent in case of dim light. Yes, in case of Horner's syndrome. Is that clear? So our patient presents with droopiness of left eyelid. There is anisocoria, normal extraocular movements. Honors is not going to affect any of the extraocular movements. So which of the following is the most likely diagnosis? So we've already ruled out CPEO because extraocular motility is definitely affected. All the gazes, the movements are restricted in CPEO. Then third nerve palsy, yes, you do have diplopia and you have extraocular motility affected, but in our patient was reverse. And I told you, put a dabba. What dabba? Myasthenia gravis pupil is not affected, so no anisocoria. So only option that is left is Horner's syndrome. Yes, let me take your questions. Ma'am, what is the difference between POAG and angle closure glaucoma? Can I come to this question at the end, beta? Yeah, I'll surely explain this. I'll come to it at the end. Oh, hi, Satvik, you changed. Okay, beta, please. Very good, very good. Lovely. Lovely. Congratulations. Okay, so now let's go to the second question. A 30-year-old female presents with recurrent attacks of left optic neuritis with worsening of vision with each attack. Right now the vision in the left eye is 2/60. What does 2/60 actually mean? 2/60 means the patient is standing at a 6 meter he's standing at 2 meter distance and looking at the first line. He's able to read the first line standing at 2 meter, not the standard 6 meters. He's even closer. That is 2/60. Okay. MRI shows enhancement of optic nerve extending up to chiasma. What is the most likely diagnosis? Okay, some of the age. So the options are neuromyelitis optica, myasthenia gravis, multiple sclerosis, and systemic lupus erythematosus. Now, a 30-year-old female. See, a 30-year-old female with optic neuritis, it can be both multiple sclerosis and neuromyelitis optica. It can be either, because in both of them, it is this 20s to 40s age group. Yeah. So just by that demographic data, I have not arrived at any conclusion. But now something is striking. Recurrent attacks of optic neuritis. See, whenever this point of recurrent attack of optic neuritis comes in, always keep this neuromyelitis optica as a differential diagnosis. Okay, I'm not saying put it at number 1, but keep it as a differential diagnosis. All right. Now, his vision is worsening with every attack. See, normally multiple sclerosis, optic neuritis, what happens is eventually there will be a visual recovery. There's not much of a worsening. When you treat or you don't treat, it kind of recovers. Whereas again, when it is worsening or it is not improving, then always suspect neuromyelitis optica. I'll tell you at the end of this question, I will tell you how to suspect neuromyelitis optica in detail. Okay. And now look at this. Enhancement of optic nerve extending into the chiasma. Now that is a giveaway. See, that's a very, very typical thing of neuromyelitis optica. See, actually now we don't call it just NMO, we call it NMOSD because it's a huge spectrum. So neuromyelitis optica spectrum disorder, NMOSD, also known as Devick's disease. That was an older name. Yeah. So when you have a longer involvement of the optic nerve, the entire optic nerve, the retrobulbar or the intraorbital portion extending into the intracanalicular and intracranial up to the chiasma. Okay, so when you have a lengthier involvement, longer involvement of the optic nerve, always suspect neuromyelitis optica. And here we are not mentioning any brain MRI findings. That's another clincher, because if there is something to do with the MRI of the brain and I've got some periventricular plaques or something of that sort, then probably I would lean towards multiple sclerosis. But here everything is telling me to lean towards suspect neuromyelitis optica. Yeah. So what is the most likely diagnosis? Neuromyelitis optica. So now I'll tell you the points in your question or in your clinical scenario when you should think of neuromyelitis optica. See, always the first attack don't suspect NMO. Always suspect the most common cause. Like we always say, no, whenever you hear the sound of the hooves or sound of the hooves, you don't think of the zebra, you always think of the horse. See, now if I hear the sound outside, I will not think a zebra is crossing my place. No, it's very unusual unless I'm living in a zoo. Yeah, or I'm living in a forest full of zebras. It's more commonly likely to be horses. So always think of the most common thing. First attack of optic neuritis, think of multiple sclerosis. Is that clear? Now, if there is something written about recurrent optic neuritis, yes, a recurrent optic neuritis, then painless optic neuritis, bilateral optic neuritis, and there is a very much a profound loss of vision, much more than the optic neuritis in multiple sclerosis. Okay, so the loss of vision is of greater magnitude, and there is lack of improvement. Yeah, when there's lack of improvement after an attack, because after a month we usually expect an improvement. Now when there is lack of improvement, again suspect neuromyelitis optica. Now if your MRI is showing this lengthy involvement, as in extending into the more than half the length of, first of all, more than half the length of your intraorbital portion, then extending into the intracanalicular, going up to the chiasma, not the optic tract, going up to the chiasma. And when you have spine involvement, if they give anything like that, okay, MRI of the spine where you have cavitation, 3 or more segments, again remember everything L, longer involvement. Okay, so what we call a longitudinally extensive involvement. Okay, so more than 3 vertebral segments, 3 or more. And if our questions will not give, suppose you're giving USMLE, then probably somebody of an Asian origin, okay, Asian ancestry. If there is any history of hiccup, hitchki. So all this will point towards neuromyelitis optica. Is that clear? So already we would have already done MRI in the first attack. Now no need to repeat the MRI. Kindly do aquaporin 4 antibodies levels in the serum. That is very specific for neuromyelitis optica. Is that clear? It's got a 94% specificity for NMO. Which one? Aquaporin 4 antibody in the serum. Yeah. And another take home. So the other option here, why I had given this in the question, was, if you remember, there was a systemic, I'm sorry, what is that? SLE. So sorry guys. So where were we? So SLE in the option. Now why was SLE even in the option? See, if there is a patient who has an attack of optic neuritis, a patient of SLE or certain autoimmune disorders with an attack of optic neuritis, always suspect neuromyelitis optica. Is that clear? So suppose there's a patient of Sjogren's or SLE or myasthenia gravis, yeah, or sarcoidosis, these kind of autoimmune diseases, if they develop an attack of optic neuritis, do aquaporin 4 antibodies, and of course you'll do MRI of the orbits and along with the spine, yeah, to rule out NMO. So autoimmune disease, patient already has a diagnosis and he gets an attack of optic neuritis, suspect NMO. Is that clear? Right. Now question, are there any questions pertaining to this one? What is the difference between management of... can I come to your question? Who's that? Beta, Ajul, can I take your question at the end? Because it's not related directly to my question. So I'll definitely answer your question, but towards the end, okay? Now question number 3, a 65-year-old male, quite old, with history of hypertension, hyperlipidemia, diabetes, what is not there, everything is there, just like all of us, develops sudden loss of vision in the right eye. No history of trauma. There is right-sided RAPD. What is RAPD? Relative afferent pupillary defect. And fundus exam is yet to be done. That means we are running through the differentials in our mind. Which of the following is least likely to be the cause of his decreased vision? Look at this question. They are wording it in such a way, all except least likely to be the cause of decreased vision. See, one thing you should notice here, they have not told us whether it is painful or painless. That they have not told us. Okay. So now, central option A, central retinal artery occlusion. Say central retinal artery occlusion, will it cause a sudden loss of vision? Yes, sudden but painless loss of vision. Typical history, an older individual with history of hypertension, hyperlipidemia, because hypertension is the most common cause, no? The atheromatous plaque from the carotid artery is sending the embolus, yes? So again, it can cause with RAPD in CRAO. CRVO, possible? Yes, because he's got all the risk factors, and although it may not be that sudden, it's a little subacute, but let's, mark it, keep it for review, come back to this option. CRVO, possible, especially when you have an ischemic CRVO with all these risk factors. My goodness, look at that. Hyperlipidemia, diabetes, hypertension, everything is there. And ischemic CRVO, yes, you can have RAPD as well. So let's keep it. We'll come back to review. Optic atrophy. Option C, optic atrophy. Guys, optic atrophy will not cause a sudden loss of vision. Yes, optic atrophy will never cause a sudden loss of vision. It is usually a slower, slower, or even can be subacute, but never sudden. Okay, so optic atrophy is not at all. Now let's look at option D, anterior ischemic optic neuropathy. Yes, hypertension, atherosclerosis is the most common cause of non-arteritic AION. Yes, so it is very much a cause. So they are asking us which of the following is least likely. So out of CRAO, CRVO, optic atrophy, and AION, which is least likely? All except optic atrophy. Is that clear? Yes. Anything? Okay. Next question. I'll take up your doubts towards the end, because these are not concerning the particular topic of discussion, my questions. Okay, so I'll come to it at the end. Yeah, clear, Farwa? Very good. All right, question number 4. A 35-year-old patient presents with redness of right eye, photophobia, reduced vision. Cornea is hazy, pupil is irregular, AC is shallow, IOP is high. Which of the following drugs should be administered to this patient? So what is a diagnosis, you think? 35-year-old patient, pretty young patient, redness, reduced vision, photophobia. Okay, now I'm not getting anything from this. Okay, cornea is hazy. And they're saying IOP is high. Whenever the IOP is high, the cornea is going to be hazy. Why? Because whenever your IOP is high, the corneal endothelial pump will not function. What is the function of this corneal endothelial pump? First of all, what is corneal endothelial pump? It is your sodium potassium ATPase. Now, what is the sodium potassium ATPase going to do? Is it going to pump out water? No. It is going to create just the ionic gradient. You remember the first day in physiology class, you would have learnt about this. First day, first year MBBS, sodium potassium ATPase pump. They would have told you about so many things, and there is an ionic gradient that it establishes. So now, that is an active mechanism. Now, passively water will move, to equilibrate this ionic gradient. So, water will move from corneal stroma into the aqueous humor. So, that cornea is relatively dehydrated and transparent. So, when the IOP is increased in the aqueous humor side, this endothelial pump will stop functioning. So the ionic gradient is not established, so the water does not come out of the stroma. So water logs in the stroma. So you get corneal edema, cornea is hazy. So that is going to happen anytime the IOP is high. So that doesn't tell me that this is glaucoma. Let's see, because they say pupil is irregular. Why would pupil be irregular in glaucoma? See, if you are thinking of IOP high and angle closure attack or something like that, angle closure attack has a typical pupil, mid-dilated pupil. Whether it is vertically oval or not, that is secondary. Mid-dilated, definitely, not irregular. Irregular means something synechiae are there, posterior synechiae are there. So that means this is uveitis. So uveitis, again, anterior uveitis or iridocyclitis, yes, you do get increased IOP, because in uveitis there is a lot of protein floating in the aqueous. So all this protein will go and clog the trabecular meshwork. So what is going to happen if something is going to block your trabecular meshwork? Aqueous cannot go out, so the pressure will increase. Yeah, so you can have a hazy cornea. Not just because of that, even because of the keratic precipitates. I'll give you a beautiful image of keratic precipitates. Tomorrow I'll put up the video, okay? So beautiful it is. So that keratic precipitates on the cornea again can cause haziness. Yeah. And the AC can be shallow because probably the amount of posterior synechiae, or there is ring synechiae. They've not mentioned about ring synechiae, they just said irregular. But yes, the AC can be shallow because in certain areas it can be shallow or probably irregular, and the question is kind of ambiguous about it. They said it is shallow. So I know definitely this is not glaucoma. Oral acetazolamide. Now my primary concern is not to decrease the IOP. My primary concern is to address the diagnosis, which is anterior uveitis or iridocyclitis. So for that, what do I need to do? I need to give steroids, topical steroids. Yeah. So oral acetazolamide is to decrease the intraocular pressure. That is not my priority right now. So that is out of the question. Timolol eye drops. Again, I have to give eventually, but that is not my primary concern. So again, no. Prednisolone eye drops. Yes, a very strong steroid or a high potency steroid is what we need to give. So prednisolone eye drops is the treatment, that is the drug that we need to give. Pilocarpine. See, this is not an angle closure attack. If it were an angle closure attack, agree, we have to give pilocarpine eye drops. This is not angle closure attack. Is that clear to everyone? Yeah? Alright. I'm just seeing your question, Raza. Yes, anterior ischemic optic neuropathy is sudden because your optic nerve is deprived of blood supply. See, if your retina is deprived of blood supply, if your optic nerve is deprived of blood supply, immediately there will be decrease in vision, sudden drop in vision. Is that clear? Yeah? Okay, what is the other question? KPs can be present in the KPs can be present in typically in anterior uveitis. It can also be present in intermediate uveitis. That is, intermediate uveitis is when your pars plana vitreous is involved. But when there is a spillover, there's no compound wall as such. Not like us, we build a high compound wall and sit inside, or put an electrical fencing, not like that. So sometimes the inflammation can spill over to the anterior bit. So in that case, yes, you can have, because of the spillover anterior uveitis. Is that clear? Beta. Intermediate uveitis per se will not cause KPs, but if there is a spillover anterior uveitis, yes, we can have keratic precipitates. Yeah, irregular pupil, what they mean is the festoned pupil. Yes, exactly. Yeah, got it? Okay, so we'll go to the next question. A patient underwent right eye cataract surgery 6 months ago. He now presents with complaints of reduced vision and glare while driving at night. Since the last 1 month, which of the following is the most likely cause of his symptoms? Most of you answered it very well, which is posterior capsular opacification, also called as after cataract. See, whenever there is PCO or after cataract, there is a slow, painless, progressive decrease in vision. Okay, slow, progressive, painless decrease in vision. And this can start from 1 month after cataract surgery. It can go on. Usually it starts around 3 months after cataract surgery. Now this patient is 6 months post-op, and apart from that painless decrease in vision, it also causes glare, and that glare again will be typically at night, especially when he is seeing the oncoming headlights. Is that clear? That's pretty easy. Let's also look at the other options. Delayed end-off. See, endophthalmitis, guys, will be a sudden painful decrease in vision. Okay, sudden painful decrease in vision, and there will be redness, none of which is there in our patient here. Complicated cataract. No, yaar, he already cataract surgery ho gaya hai. So already cataract surgery is over. Why would we have a diagnosis of complicated cataract? No, I'm so happy none of you marked it. Lost IOL syndrome. See, what is a lost IOL syndrome? When the IOL drops into the vitreous, maybe there is a posterior capsular rupture and still be placed in IOL, and the IOL just fell into the vitreous posteriorly. So in that case, the patient will have a painless decrease in vision. He is almost equivalent to an aphakic, aphakic patient. So he will not have glare, and he will have not over 1 month, slow, progressive, and all sudden. Okay, because what happens? Aphakia is a state of high hypermetropia, right? The refraction that is contributed by your lens or your IOL is completely gone. So this is aphakia. Is that clear? So we'll move to the next question. Any question pertaining to this, any doubts pertaining to this question, please post it. The next question, a patient is being reviewed on day 1 post-op. Remember that, okay? Day 1 post-op, after left eye cataract surgery, the eye is red, cornea is hazy, aqueous cells 2+, sun working red classification 2+, flare 2+, which is quite significant. Posterior segment is normal. Now, what is posterior segment? Say any structure that is behind the posterior capsule of the lens is called posterior segment. Is that clear to everyone? This was a PYQ, trust me. How do you define posterior segment of eyeball? Any structure anterior to it is anterior to the posterior capsule of lens. You know the lens is biconvex, I have an anterior capsule and a posterior capsule. So this posterior capsule is a landmark with which we define anterior segment and posterior segment. So they say posterior segment is normal. That means vitreous is normal, retina is normal, optic nerve is normal. Is that clear? Is that clear? Okay. Now, what is the best management strategy? So you know you should find out the diagnosis and devise the management for this patient. So option A, posterior subtenon triamcinolone. As far as I know and you know, posterior subtenon PST is given for intermediate uveitis. I mean, we do give other indications, but intermediate uveitis, yes, we do give PST, posterior subtenon injection, of which steroid? Triamcinolone acetonide. Alright. This doesn't look like intermediate uveitis to me. Because intermediate uveitis, again, another MCQ, which is a primary site of inflammation in intermediate uveitis. It is a vitreous cavity. So when I say posterior segment is normal, obviously it's ruled out. So I guess option A, I can very safely rule out. Okay. Option B, intracameral vancomycin. What is intracameral, guys? Again, a previously asked question. Intracameral means administering anything into the anterior chamber, into the aqueous. Okay, intracameral injection. So intracameral injection vancomycin. Why would I give that? I wouldn't give that. What kind of diagnosis do I have in mind? I don't have anything of that sort. I can safely play with this also and rule out. Okay, now anyway, I'll go to option 3. Vitreous tap and intravitreal antibiotics. See, vitreous tap and intravitreal antibiotics, where have I taught you this? I taught you this with respect to management of endophthalmitis. Does it look like endophthalmitis? Eye is red, okay. Cornea is hazy, okay. Aqueous is involved, okay. There is cell and flare. But posterior segment is normal, na? See, endophthalmitis, ophthalmos means eyeball. Endo means inside. All the cavities of the eyeball should be affected. My aqueous and my vitreous. But in my question, I have typically said my patient's posterior segment is absolutely normal. So there is no pus or no exudates in the vitreous. So how can I entertain this diagnosis of endophthalmitis and go and poke my patient and give him intravitreal antibiotic? I would not want to do that. No, it's not a diagnosis of endoph at all. You understand? See, for endoph, both my aqueous and my vitreous have to be affected. Is that clear? So here, the clincher is posterior segment is normal. So endoph is ruled out. So you don't have to do the vitreous tapping to get the vitreous sample, nor do you have to give intravitreal antibiotic. So what exactly is the diagnosis? See, you remember in INICT May 2025, there was a question which actually was about endophthalmitis, but there was an option called TAS, Toxic Anterior Segment Syndrome, TASS, Toxic Anterior Segment Syndrome. So the AS, anterior segment, is involved. So there is a sterile inflammation involving the anterior segment, exactly like this patient, day 1. So it usually presents within 24 hours of cataract surgery. Which one? TAS. TAS presents, put it in your head, TAS presents within, most commonly within 24 hours or at the most within 48 hours of cataract surgery. It's a sterile uveitis, sterile anterior uveitis, meaning there is no infection involved. Yes, there is inflammation, most likely to the kind of chemicals that we use in disinfection, like ethylene gas that we use for disinfection. So there's an inflammation to it. Okay, so because it is an anterior sterile anterior uveitis, all that you need to give is steroids, topical steroids. So posterior subtenon, triamcinolone, no. Intracameral vancomycin, why? Yeah. Intravitreal antibiotic, not at all needed. prednisolone eye drops. So you have to give high potency prednisolone. Steroids here again, okay? Prednisolone eye drops, and of course you will also give cycloplegics, which goes without saying. But in this question, this is what it is. अरे किसने क्या लिखा? Ma'am please answer. अरे लिख करती हूँ. ठीक है, मैं ये कैन आई फिनिश 4 more questions बेटा? अभी 4 questions बाकी हैं हमारे क्विज से, वो मैं खत्म करती हूँ, फिर उसके बाद आपके जो भी डाउट्स हैं मैं आंसर करती हूँ. ओके, एज लॉन्ग एज इट्स नॉट वेरी एम्बिगुअस, वेरी स्पेसिफिक डाउट्स आई विल क्लियर. ओके. 7th question. A 70-year-old female with history of diabetes and hypertension developed recent onset diplopia, which increases on looking to the left. What is the best management strategy? So basically you see a 70-year-old female both diabetes and hypertension, so is very likely to get the microvascular complications. So she can get microvascular complications like cranial nerve palsy, which is most common. Your 6th nerve palsy is very common because of these microvascular complications of both diabetes per se and hypertension per se, and now this lady has both. So she's actually developed 6th nerve palsy on the left side. So when she's got left-sided 6th nerve palsy, what is going to happen? See, what is the function of your lateral rectus? 6th nerve is supplying your lateral rectus. So this is my left eye, my lateral rectus is here. So the function of my lateral rectus is to abduct the eye, take the eye horizontally outward. Yes. So when I have a 6th nerve palsy, my lateral rectus is going to be palsied, so it cannot go out. So my medial rectus will act. So I will get an adducted eye, or I will get a convergent squint, because this eye is looking straight. This is a convergent squint. You get it? My smiley, is it oriented properly? Yeah. So I get a convergent squint or an ezo squint, what we call esotropia. So this lady is getting a left esotropia. So that's why a diplopia. So one eye is looking straight, one eye is looking somewhere else, double image. It's going to be a binocular diplopia. Now this diplopia is going to increase whenever the eye tries to go into the field of action of the paralyzed muscle. So when I look to the left, to my left, then I will know the poorly acting LR's LR's function. Yes, it will come out. So that is why the diplopia, as I say, the diplopia is increasing when she's looking to the left, because when I look to the left, my left lateral rectus has to act. I think you're getting it laterally reversed. So my left lateral rectus has to act. But it is not acting. So my diplopia will further increase, because this eye goes here, but this eye remains somewhat, maybe comes to the midline or maybe not. So the diplopia will increase in left gaze in case of left lateral rectus palsy. Did you understand this? So now what is the best management? So this kind of 6th nerve palsy due to these microvascular complications of hypertension and diabetes, most commonly they will resolve in 3 months or at the most 6 months. So don't do anything, observe and make sure that the diabetes is under control, the hypertension is under control, any other risk factors, everything under control. If even after that the patient has persisting squint and also the diplopia is affecting the patient, then probably we can try something. So until then, what to do for the diplopia? Maybe patch the squinting eye, just patch the squinting eye, or probably give the patient prisms in the glasses, incorporate prisms in the glasses, or maybe if the patient is very insistent and the patient is willing to pay some money, then we can give botulinum toxin into this overacting antagonist, ipsilateral antagonist. But again, there'll be problems in the other gazes, so not a great idea. So maybe just patching for the diplopia. Okay, so can we go to the next question? So did you understand? So no need to immediately, don't go and operate on the patient, just observe for 3 months at least. Now the next question, a young fair skinned tall boy presents with diplopia. He has hyperextensible fingers, frequent history of fractures. Diplopia is monocular, that means uniocular diplopia in his left eye. Which of the following supplements would be beneficial to him? So basically, what is the diagnosis? See, he's got Marfanoid features, but that doesn't mean he has Marfan syndrome. Tall, hyperextensible fingers, but he's fair skinned, which my Marfan's kid or patient would not have. History of fractures. History of fractures suggests osteoporosis. Yeah, and this diagnosis is your homocystinuria. So homocystinuria patient will be tall with hyperextensible fingers and joints, just like our Marfan's. That's why Marfanoid features. Then history of frequent fractures because osteoporosis is there. Then they have thromboembolic tendency because of the hyperhomocystinemia. Okay, which is not given in the picture, of course, because these patients are prone to get ectopia lentis. So the dislocation or subluxation of the lens has caused not dislocation. Dislocation is completely, the lens is not in the pupillary area. So this is partial, so subluxation. That is why the patient is having uniocular diplopia. Now, what supplement is going to help this patient? In certain subtypes of homocystinuria, vitamin B6 supplementation, that is pyridoxine. Is that clear? So this I had actually discussed in one of my test and discussion series. I had given it as an original question and it was asked in NEET PG 2024 after I had given in my TND. So take my TNDs very, very seriously. Okay. Not this Telegram quiz, it was in the TND session. So pyridoxine, vitamin B6. Now I had given hydroxycobalamin. No, nothing. Not your vitamin B12. Idibinone. Now why this idibinone? Idibinone is recently the only one which is FDA approved for Leber's hereditary optic neuropathy. Okay, this option C, idibinone, is the only one which is of proven benefit in Leber's hereditary optic neuropathy, LON. Okay, so that is something, write it down. Thymin again, not for this question. Okay, the last but one question. An 8-year-old boy is brought by his mother with complaints of itching and sticky discharge. He rubs his eye frequently. Oh my god, there's a typo there. A diagnosis of vernal keratoconjunctivitis, that is spring cutter, is made. Then when I read this question, I think, Arey, you given the diagnosis also, what do you want me to do? Okay, let's see. Olopatadine eye drops is prescribed. Oh my god, even that, what exactly are we supposed to do? It's like Google is doing everything. Okay, he is advised not to rub his eyes. Okay, to prevent what? Okay, finally something for my brain also. So we know this is a case of vernal keratoconjunctivitis. We've given the drug of choice olopatadine as well. But now the question to you is, you ask the patient not to rub the eyes so frequently, because rubbing the eyes so frequently causes epithelial thinning, corneal epithelial thinning, and this corneal epithelial thinning is a risk factor for keratoconus development, secondary keratoconus in these patients. Is that clear? So keratoconus, I don't know why some people have marked this Leber's congenital amaurosis. No, congenital, maybe you knew too much. See, Leber's congenital amaurosis, there is this young child who constantly poke his eyes, eye poking is a very, very, very kind of a pathognomonic complaint told by the patients of Leber's congenital amaurosis parents. Okay, they'll bring the child saying, we're so scared that the child is, poking deep into the eye or the orbit, that is for LCA. But here, eye rubbing, just muscle na. Itna nahi muscle na hai, because of the epithelial thinning that occurs, and that can be a risk factor for subsequent development of secondary keratoconus. Yeah. All right. Now the last question, the quiz. Industrial worker presents with chemical injury. Which of the following is the first step in management? This is a previous year question actually. So one option, thorough irrigation with tap water. That is the first thing you will do. Okay, that's the first thing you will do. Because you need to dilute the amount of chemical that is present in and around the eye. So run through copious, see, although I've written tap water, just ensure that it is clean tap water. That's all. We're not looking for any distilled water. We're not looking for anything. Even if you get some decently clean tap water, that is good enough. Option 2, antidote administration. Never ever waste time looking for antidote. Okay, never. Even if you have the antidote, even if as an ophthalmologist, even if let's say my practice is in an industrial area, and I do have antidotes based on the history of my patients who keep coming frequently. Even then, first thing I will do is copiously irrigate, because I will want to cleanse the eye. I would want to dilute the amount of chemical that is present in the eye and in the fornices, and then probably administer the antidote. Okay, so the question is very clear about what it wants to know. So it's the first step in management. So option B is ruled out. Detailed history regarding the nature of the chemical. Mataji, don't ever go there. Okay? No, you don't want, you know there's a chemical injury. इतना तो patient will tell you ना, इतना तो बताएगा. तो ऐसा आके तो मुंह बंद करके तो नहीं बैठेगा ना सामने, तो बोलेगा कि मैडम जी मैं तो कुछ पेंटर हूँ, मैं तो कुछ ये वाला काम करता था, I was doing this kind of work, something fell into my eye. This much he will say, that is enough. You don't have to go into the detail of what brand, what is the concentration, कितना volume गिरा. You don't have to ask anything of that sort. Okay, so detailed history, no need. So ruled out. Sweeping of the furnaces. See, why do I want to sweep the furnaces? That is subsequently, you know, once I start the management, probably from the next day or something, because chemical injuries will have raw conjunctival surfaces, and I do not want the formation of symblepharon. So anytime I have thermal and chemical injuries or even radiation injuries sometimes, I do not want the formation of symblepharon, only for that reason, and that is not in the immediate management at all. It is only in the subsequent management. All right, so okay, let me take your questions. Better latest anti-VEGFs I actually discussed in another video. No, Botox will not cause CRAO. Who said? No. Yeah, patching. See, diplopia is because one eye is looking somewhere and the other eye is looking straight. No. See, if I close either of the eye, this eye or this eye, the diplopia will disappear. But why do I want to close the normal eye, patch the normal eye? I would want to close this eye, no? Squinting eye. I'll come to your anti-VEGFs at the end, beta. Usse pehle, no? Whoever asks is Vijay. I'll come to your latest anti-VEGFs towards the end. Okay, first let me clear up these pending doubts they've asked and they've been patiently waiting for the last half an hour. So patching is usually of the squinting eye, not the normal eye, not the straight eye. Okay? Botox will not cause CRAO unless you do something else. I don't know why. Botox, no. KP, okay, that I've answered. Festoon pupil. Ma'am, answer preseptal cellulite. But a preseptal cellulitis and orbital cellulitis is, there's a anatomical structure in the eye called as orbital septum. So this orbital septum actually goes from the superior orbital rim, है ना, वो bone है ना, from the bone it goes down to the tarsal plate, okay, to the anterior surface of the tarsal plate in front of the LPS. So it's like a parda, it's like a curtain. So any structure that is inflamed anterior to this orbital septum is preseptal cellulitis. So these are less serious structures. So it's benign. Okay, there's an inflammation. Yes, there'll be lid swelling and all that, but it's benign. But orbital cellulitis is involvement of structures posterior to the orbital septum. So all the serious structures are there. Yeah. So again, orbital cellulitis is an ophthalmic emergency. Is that clear? So that's the basic difference. So when I have orbital cellulitis, that means what are my most important structures? My optic nerve. So I told you, optic nerve affected, there will be definitely decrease in vision, color vision, decrease in color vision. And another is optic nerve is responsible for your pupillary light reflex. So you will have RAPD in orbital cellulitis. Okay? And extraocular motility will be affected in orbital cellulitis. So patient can have diplopia, and when you check, the extraocular motility will be affected. Now that is mainly because of cranial nerve palsies that can affect because of involvement of the orbital apex and all. So that is orbital cellulitis in a nutshell, the differences between. So whatever I told for orbital cellulitis, uska ekdam ulta. So all these parameters will be normal. Visual in preseptal cellulitis, visual acuity is normal, color vision is normal, pupillary light reflex is normal, extraocular motility is full, there is no diplopia. Is that clear? These are 5 points to differentiate between preseptal cellulitis and orbital cellulitis. But it's so easy, nothing. Okay, all right. What is the other question? True membranous conjunctivitis. But true membrane is, there is a, true membrane and pseudomembrane. What is the difference? See, true membrane is you do have the exudation, and that exudation will infiltrate into the conjunctival tissues. So, एकदम adherent है वो एकदम मतलब it has grown into the tissue ना. तो जब when you are trying to remove it, when you are trying to peel it, it is first of all very difficult to peel, true membranous. And अगर आप peel भी किया ना, because there will be this vessels that have grown into it. It will have bleeder. It will start bleeding when you peel it. Yeah, and exactly opposite your pseudomembranous, it's just चिपका हुआ है ऊपर से, तो वो बहुत आसानी से very easily you can peel it off and there will be no bleeding when you peel it. Yeah. Yeah, management of traumatic mydriasis. But actually traumatic mydriasis we don't try to manage it much, because there will be radial tears of the sphincter. So once there is a tear in the sphincter, pharmacologically, maybe if you give pilocarpine, and there's just fewer areas of sphincter tears, still it will constrict. But pilocarpine you can't give for a longer period. If the traumatic mydriasis is too much, the mydriasis is too much, causing photophobia to the patient, we can give pilocarpine depending on the level of the clock hour involvement of the sphincter tears. Number one, you can give pilocarpine, very dilute you can dilute pilocarpine to a certain extent and give. Ask a patient to wear dark goggles, or if it is too much to bear, you can give what is like these contact lenses with small visual axis. You can give contact lens to decrease the amount of light that goes in. That can be given. Tinted contact lenses with a small aperture, that can be given. Or very rarely there can be a pupilloplasty, a surgical repair of the pupil can be done. Yeah, that is your traumatic mydriasis. Hey, what is the difference between POAG? This is a whole glaucoma topic, man. Go and watch the videos on the EyeMentor app. It will take you 2-3 hours solid. See, latest anti-VEGFs are your Conbercept, then your Brolucizumab. So these are your main latest anti-VEGFs. These are the two main latest ones which are in clinical use, Conbercept and Brolucizumab. Part 3 step test, Bharati, I will give you the link of the video where I've explained in detail. Okay, I'll explain that in detail. It's up without pen and paper, because in exam you don't get a pen or a paper, so only your finger you use, and you can do the part 3 step test. I will give the link, you watch that in detail, but right now I will explain it to you in a very assuming you know everything. Okay, so we'll take a question which says, let's say a right hypertropia, patient presents with right hypertropia which is increasing in right gaze and right head tilt. And the question I'll explain now, but further down I will also advise you to look up my previous video. Okay, so right hypertropia means right eye is up. So the right eye is actually up, or because the left eye is down, it looks up. It's normal, but the left eye has gone down, so there is right is up. Okay, so anyway, if my right is hypertropia, that is because my right depressors are not working. Which are my depressors? My superior oblique is a depressor and my inferior rectus is a depressor. Superior oblique, why I am giving a finger here is, superior oblique is a depressor in an adducted eye. Adducted eye, it will depress. So if I have to look here, do you see? So if I have to look here, my right, this SO is working. It is causing depression of an adducted eye. And if I look this way, this is my inferior rectus working of this side. Okay, so inferior rectus is a depressor of an abducted eye, superior oblique is a depressor of an adducted eye. Clear? So now if my right eye is up, either my depressors of this eye are not working, or it could be the elevators of this eye not working, so this eye is actually down. So guys, are you getting a lateral reversal? Because I think YouTube gives it that way. I am using my right eye here, so let me point it this way, because you have a lateral reversal, it will be easier for you to understand. So right hypertropia, that means my right depressors are not working, so my right eye is up, or my left elevators are not working, so my left eye is down. So any which way, right hypertropia, right is relatively up or absolutely up. Now I also said the right hypertropia is increasing on right gaze. So this is my right gaze. So you keep your finger on your depressor. When I say depressor, keep it on the inferior orbital rim. When I say elevators, keep it on the superior orbital rim and don't think anything more. Okay, don't even go to imagine what muscle here, no need. Okay, not this chincha, we don't want to do. Then right gaze, slide your fingers towards the right. Okay, just slide your fingers towards the right. Now again, don't worry about which muscles we are pointing at. Just slide your fingers. So my finger is here and here. So 2 muscles are my suspects. Now, which 2 muscles? Let's not worry. Now, what is there in the third step? We said the hypertropia is increasing in right head tilt. See, what is the concept here? Now, remember my position is here and here. Okay, I'll just explain this. Now, right head tilt means normally what happens when you and I, you tilt your head, no? You tilt your head. Yes. Typical Indian head shake. Okay. So when you say okay, your eyes cannot roll like this. See, when I say okay, dung, eyes go doing. And then another sit this side, doing. My eyes cannot roll like this and my whole world cannot keep tilting. So the moment my head tilts like this, my eye will have a counter rolling mechanism. Okay, it will try to tilt, but this counter rolling mechanism will keep it in proper position. So when I tilt my head like this, I will have a counter rolling mechanism like this. When I tilt my head like this, counter rolling mechanism like this. This is normal. Okay. So now when I'm talking about increasing in right head tilt. So in right head tilt, the muscles that have to act is this eye. It has to, see, the eye, listen very carefully. The eye is trying to go toing, out, extortion, because my head is tilting this way. But a corrective movement should be an intorsion. So in this eye, it has to be, that is my right eye, my SO has to act. SO is a intorter, yes. Superior oblique is intorter, yes. Now, in this eye, it is going intorsion, toing. Now the counter rolling should be toing, extorsion. So in my left eye, it has to be inferior oblique. Is that clear? So now, right, do you understand the counter rolling mechanism? Now, I am only talking about, now coming back to the question. It is increasing in right tilt. So right tilt, in the right eye, it has to be my intorters. Which are my intorters? Both my sin, superior oblique, and also my superior rectus. Yes. So in my right eye, it should be either, it could be either SO or SR. So where were my fingers? My fingers were here. Do you remember the end of the second step? So right hypertropia, either because my depressor is not working here or my elevator is not working here. Right gaze, so I came here. And right head tilt, it has to be, I'm looking for the SO and SR. Is it SO and SR? The positions of SO and SR are this and this, whereas my finger is here. You understand what I'm trying to say? The counter rolling mechanism is intorsion. Intorsion is done by superior oblique, which depresses an adducted eye, and superior rectus, which elevates an abducted eye. Either this position or this position, but my finger is not in any of these. It is here. So this is not the culprit. So the culprit is, ta-da, take this off. This one. What is this muscle? Left-sided. This is superior oblique. Depression of adducted eye. This is pointing towards the nose but up. So left inferior oblique. So my implicated muscle is left inferior oblique. Okay. So Bharat, watch this again. And also that original video where I've explained in detail, because I've explained the functions of the muscles, I've explained, and then at the Tamil Kuda I have explained. So you can watch it. Tamil portion will come towards the end. Watch the entire video. I think it's like 15-20 minutes video. Yeah. Oh my god, the session has gone for an hour. Alright guys, so shall we take leave? Can I bid adieu? Any other doubts, ma? Vijay, these two are the latest anti-VEGFs. Okay, if you another is not, it's not a typical anti-VEGF. It is a bispecific antibody which targets both your angiopoietin 2 receptor and angiopoietin 2 and VEGF, which is faricimab. And And the other the type the other day I talked about tyrosine K inhibitors, okay, tyrosine kinase inhibitors, because they have a bigger bandwidth. They inhibit VEGF then receptors, then they also inhibit PDGF. So that will not come exclusively under a dual anti-VEGF. If you want, you can go through that also maybe. ஓகே, நான் லிங்க் வந்து ஐ வில் இந்த செஷன் முடிஞ்சதும் நான் கமெண்ட்டில் போடுறேன்ப்பா. ஓகே, ஆஃப்டர் திஸ் செஷன் இஸ் ஓவர் I will put it in the comment section because I'll have to search and put it. Okay, you watch it. All right. Okay, so any other doubts? Okay, lovely guys, lovely. So I'll see you tomorrow. Tomorrow, what is the topic for the quiz? 6 p.m. quiz. I guess tomorrow is Ophthal IBQs if I'm not wrong. One second, let me check. Yeah, tomorrow is Ophthal image-based questions. So prepare well, and 9 p.m. here we'll have the discussion. All right. So thank you for all the hearts you've been giving me in between. Lovely. Okay. Good night, all of you.